You know that feeling? Maybe you're handed like an HL7 message, or you find yourself sitting in a meeting
Hmm.
and they're talking data exchange, fire, maybe identity federation, and you just feel, well, kind of lost.
Oh, definitely. Like you're seeing bits and pieces, but not the whole map.
Exactly. Maybe you're even, discreetly Googling terms under the table. Happens to the best of us.
It's incredibly common in health IT. It's like being given that map showing just a few street corners.
Yeah.
You see something, but how do you get from A to B? Or even see the whole city layout?
Right. And that disconnect, that feeling, it's important to say it's usually not about your capability. It's often just that nobody's really showing you the whole system clearly.
Right.
So today we're exploring why it feels so complex based on some interesting perspectives and what a more effective way to approach it might look like.
And a key thing that comes through is that this complexity, especially when we talk about health information exchange, HIE sharing patient data,
Yeah.
it's not simple. It's inherently layered. It's meant to be complex in some ways.
Layered is a good word. Think about it. First, you've got the actual clinical data itself. Lab results, meds, allergies.
Yep, the core information.
Then layer on top the huge variety of systems holding that data. EMRs, EHRs, clinic systems, labs, pharmacies, all needing to somehow communicate.
And then there are the rules, regulatory requirements like privacy rules, saying when and how you can share data, consent management.
Plus security. Protecting the data, encryption, who gets access, that's another huge layer.
And then you get the standards, HL7, version 2, version 3 sometimes, CDA documents, fire resources, those ITI profiles.
Yeah.
They're supposed to help, but honestly, learning them can feel like just another layer of complexity sometimes.
Don't forget the acronyms. Just an endless sea of acronyms adding to the fun.
Ah, true. And it's interesting how different roles look at the very same challenge, right?
Yeah, like a clinical analyst, an integration developer, maybe a security architect.
They're all looking at the same data exchange problem, but from really different and necessary viewpoints. It's a bit like that old story.
The blind scholars and the elephant.
Exactly. Each one
Okay.
touches a different part, the trunk, the leg,
Yeah.
the tail, and they're absolutely right about their part.
Yeah.
But agreeing on what the whole elephant looks like, that's tough.
Oh, I've definitely felt that.
Yeah.
I remember being in this high-level planning session once, talking about jurisdictional HIE,
Okay.
and hearing terms thrown around, master patient registries, complex data flows. And despite having the right job title, I just felt completely lost. It wasn't that I didn't know the definitions.
Hmm.
It was the practical connections, how it all actually fit together and worked in the real world. That was missing for me then.
And that really gets to the core realization, doesn't it? Mastering this stuff isn't really about memorizing lists of isolated standards or definitions.
Right, that's like
Yeah.
like trying to build a house by just memorizing the specs for every single type of nail and plank, but you have no floor plan.
Yeah, you've got a pile of facts, maybe, but you
Mm.
can't actually build anything useful or coherent.
Hmm. So what's the alternative? The more effective approach.
Well, it seems to be about learning to see the whole system, end to end.
Seeing the system, what does that really mean in practice?
It means needing context that goes beyond just reading the standard documents. It means maybe having a shared language, sure, but crucially, seeing how data actually moves between different points
Okay.
in a real clinical scenario,
Yeah.
and understanding the why behind that movement. Why did it need to go there? What triggered it?
The why. That seems critical. Not just what message, but why that message right now for this patient.
Precisely. And one really effective way to get that perspective is by learning through real patient data journeys.
Patient journeys. Tell me more.
It means walking step by step through common scenarios, following the information for a real, albeit maybe hypothetical, patient.
Okay, like let's imagine a patient, maybe call her Maria. She checks into the emergency department.
Perfect example. So Maria checks in. That action itself triggers data flows. Maybe an ADT message, admission, discharge, transfer gets sent out to update various systems,
Yeah.
registration, maybe billing.
Makes sense. Then maybe the doctor orders labs through the EHR.
Exactly. That order triggers another message, perhaps, or maybe an API call, going from the EHR to the lab system.
And then the results have to come back.
Right. They come back, perhaps using a standard format like an HL7 ORU R01 message, or again, maybe another API call, delivering those results right back into Maria's chart in the EHR.
Okay, I can see the flow. Imaging probably works similarly. Order out, result back.
Very similar order result flow, typically.
Okay.
Then let's say Maria gets better, she's discharged.
What happens then?
Well, that triggers another ADT message saying she's been discharged. And often, a discharge summary document is created. Maybe something like a CCDA document.
And that summary is important. It needs to get to her primary care doctor for follow-up.
Critically important. And how does that happen? Well, it could be several ways. Maybe old school fax, unfortunately, still happens. Or secure direct messaging. Or maybe the primary care doctor system can actually query for it using FHIR APIs.
Wow, okay. So following Maria's journey like that, suddenly those terms HL7, ADT, ORU, R01, FHIR, CCDA, even the privacy rules, they stop being just abstract concepts.
Exactly. They become practical. That HL7 message becomes like the envelope carrying vital information at a specific point in Maria's care. Those privacy rules become tangible design constraints. They shape how you can share that discharge summary based on consent for the purpose of the sharing.
It changes how you think day to day, doesn't it? Instead of just rattling off specs, you start asking questions grounded in the patient's actual flow.
Questions like, what information is really needed at this step for Maria? Where does that information live right now? How does it need to get to the next system? And crucially, why does it need to get there?
It ties all that technical complexity back to the reality of delivering care, makes it much more intuitive somehow.
It really does. And gaining that kind of system view, that's what helps you navigate the complexity. It helps get rid of that, that imposter feeling we sometimes get.
Yeah, that feeling.
It gives you the confidence to contribute, not just because you memorize something, but because you actually understand the underlying flow and the purpose behind it all.
So if you've been listening and you've ever felt overwhelmed, or maybe done that secret Googling in meetings, seriously, you are not alone.
Not at all. It's a super common feeling, and it often just points to needing that clearer, bigger picture, that system view.
The key isn't just piling up isolated facts, definitions, acronyms.
No, it's about understanding how they all connect, how they interact dynamically in the real world of healthcare delivery.
So maybe here's a thought to leave you with, something to mull over. Stay really curious about the how and the why.
Good advice.
Try it yourself. Pick a common scenario like admission, maybe getting a medication, getting discharged. Try to trace the journey of the information for that patient.
Yeah. Ask yourself, what data gets generated? Where does it actually need to go next? How does it get there? And always, why?
Seeing the whole system through the lens of what a patient actually experiences. It's not just possible. It sounds like it could really transform how you work and how confidently you can contribute in health IT.
Absolutely. It shifts everything from abstract knowledge to practical understanding.